So because I thought that we needed another review of concepts in epidemiology, I identified a presentation produced by this faculty member at the University of Pittsburgh that I thought did a nice job of describing study designs and also study types. So one of the keys for environmental health is that we often try to link environmental exposures to health outcomes, and we do that through epidemiology. Fundamental assumptions in epidemiology mean that disease is not just randomly distributed in a population, that it occurs for reasons. And epidemiology uses an approach to study the difference in these disease distributions in subgroups. It can allow for understanding of causal, or what causes the outcome or the disease, and prevention. In epidemiology, we will use a variety of measures. One includes the measure of disease frequency. How frequent is the disease? We can use a lot of different ways to measure that. And we will look at who's getting it, where is it occurring, when. And this can allow us to make hypotheses or research questions concerning cause and prevention. These hypotheses are often tested using epidemiologic studies. For the purposes of this presentation, we will focus on two types of studies. One is a descriptive study. We're mostly describing the occurrence of a disease outcome, and the other is an analytic study. This describes the association between an exposure and an outcome. And these are not the same as epidemiologic study designs. These are really the main purpose of the research. Are they descriptive, or are they trying to develop a hypothesis and test it? In an analytic study, we are often trying to understand whether or not an exposure is linked to the disease. And for environmental health, we're always thinking about an environmental exposure. Basic questions that are required to understand this relationship, to link the two, are: what is the exposure? Who are exposed? What are the potential health effects? And how can you study the relationship between the exposure and the outcome? There are a variety of research designs that we use in epidemiology that are considered epidemiologic study designs. Study designs help you decide how you will investigate these relationships between exposures and outcomes. They may help you just identify hypotheses, or they may formally test them. So for the next set of few minutes, we will read through and go over what designs exist and how do we use them to investigate factors related to disease. So descriptive studies are often helping us identify the distribution of disease, such as case reports, case series, or other descriptive epidemiology. Analytic may be in an attempt to understand the relationship between the exposure and the outcome. A randomized controlled trial, like the one that we saw looking at green space and vacant properties, is the most well regarded in terms of being able to isolate the effect of the exposure on disease. Other analytic study designs include a cohort study, a case control study, which we've talked about in class, a case crossover study. Cross-sectional studies can be analytic when we're testing hypotheses, but we can also consider cross-sectional studies to be descriptive. Before and after study, like the study that we saw with the testing of blood lead levels in Flint, and ecologic studies. And if you look at the list, it's often going down in terms of strength of evidence between association of the exposure, the environmental exposure, and the health outcome or the disease. RCTs, or randomized controlled trials, and cohort studies produce the strongest evidence for the links, whereas ecologic studies, which group people on geographic settings, like where they live, those are harder to use to demonstrate evidence, although they're still also considered analytic studies. We can look forward in time, where we start at one point and we follow everyone forward into the future. We will be looking at, do people develop a disease or a condition? We may also measure their exposure during that time frame. That's called a prospective study, where you look forward in time. But you can look backward in time as well. You look back in time to study events that have already occurred. You may be reviewing records of people that worked in a factory. You may be thinking about food that people consumed. This type of study is considered a retrospective study, where we look backward in time to study events. Case series, descriptive studies, they all help us develop hypotheses, whereas hypothesis testing often takes place in case control cohort studies. Descriptive studies are often used to develop hypotheses. We can do this with cross-sectional studies. We can do this with case reports. Case control studies often allow us to investigate the relationship and its outcomes. There was a case control study that your colleagues shared about Camp Lejeune and male breast cancer. Case control studies are very good for rare diseases. Cohort studies allow us to more explicitly understand the exposures, where we look at exposure and follow people to disease, either forward or backward in time. And then clinical trials, or randomized controlled trials, allow us to experimentally expose people. And in most cases for environmental health, we cannot allow people to be exposed to harmful substances, but we can allow them to be exposed to prevention. As I described earlier, as we go down this list, we get increasing knowledge of the relationship between the disease and exposure, often increasing costs to run these type of studies, but more certainty that the evidence that we have from the study is not compromised by other factors. So, descriptive studies like case reports often detail a single case or a handful of cases. I'm not sure if you've seen in the news, but there is a case report about a young boy that got tetanus in Oregon. He had never received any vaccinations in his life. He had a wound that his family sewed up at home, and about 6 days later he had what's considered lockjaw. He had a spasming of his jaw. It's one of the most common identifiable symptoms of tetanus. He was hospitalized for 8 weeks. It cost over $800,000. And he almost died because he had not received these vaccinations. But that report that came out in Morbidity Mortality Weekly, that's an example of a case report, a single case. It describes, for example, previously undescribed diseases or a unique finding. And this was a special situation because most people are vaccinated for tetanus. Case series might look at a group of patients, look at the prevalence of disease, report on new or unique condition, or for a very rare disorder, it might be the only appropriate design. Sometimes these are good for hypothesis generation. Again, good for very rare diseases that have few established risk factors. They can't study cause and effect, and they can't assess disease frequency because you're only looking at people that have cases and you don't know who the whole population that you're studying is. Descriptive epidemiology often is where population-based cases with the denominator. I would argue that many cross-sectional studies fall into this category. Analytic studies can also be considered cross-sectional, especially when you have an intentional hypothesis. Of course, the most well-respected study design for analytic epidemiology is the randomized controlled trial or the community randomization trial. But most of the time, especially in environmental health, we can't impose exposures on people. So most of the time we use observational studies. When we use observational studies where we're getting data on people in groups, that's considered an ecologic study. We don't have data on individuals, we have data on people in groups. We don't know anything about individual characteristics of disease. That's an ecologic study design. When we do have individual data, we can think about cross-sectional information, cross-sectional study design, cohort study design, case control, and case crossover. Experimental studies are ones where treatment exposures occur in a controlled environment. These are planned designs. Clinical trials are the most well-known, but you can also randomly assign groups like census tracts or block groups to the exposure, like we saw in the study that our colleagues shared about vacant lands and shootings. Observational studies are non-experimental. We don't control who's being exposed and who's not. There's no intervention. Treatment and exposures can occur in a non-controlled environment. Individuals can be observed prospectively, retrospectively, so forward in time, backward in time, or at one point in time, like in a cross-sectional study. A cross-sectional study is an observational study design that surveys exposures and disease status at one point in time, one time interval. For this, it's often good for generating hypotheses, and you can test them, but it's very difficult to isolate what direction those things are happening. You can't say that one occurred before the other since you're measuring them at the same time. Often you might group people in this cross-sectional design into disease and no disease, and then you might assess whether or not they have the factor present or absent, let's say an environmental exposure, like access to sewage treatment, like we saw in Alabama. That was a cross-sectional design. They're often used to study conditions that are frequent, sometimes chronic. They only measure prevalence. We only know that people have this at this point in time. We don't know if there are new cases occurring, like incidents. Community surveys are a good example of cross-sectional studies, and they're not really good for studying rare diseases or diseases with a short duration. Rare diseases, like very rare cancers, would be difficult to study in a cross-sectional study design. The disadvantages of these studies are that they're their weakest design. The sequence of exposure and effect may be impossible to determine. We don't usually know when the disease happened. And so it's not the strongest evidence for the study design and understanding the exposures between an environmental condition and health outcomes. Case control studies are also observational in nature, where we're comparing exposures in those who have disease versus healthy controls. One key feature of this is that you sample by disease status, and those people who have cases of the disease are classified as cases. Those people who do not have cases of the disease but have characteristics that meet those cases are classified as controls. Usually, exposure data is collected retrospectively or looking backward in time, and this is a common design when disease outcomes are rare. Very rare cancers, very rare diseases. This would be a study designed to use because you don't have to survey a large amount of people, you just identify people with the disease. The cases have the disease, the controls have no disease. Then you go back to assess what exposures they had. Did they have exposure to trichloroethylene in their drinking water? Did they live at Camp Lejeune? Did they, were they, for the male breast cancer cases in that study that your classmates shared, that's what they were looking at. These are less expensive and time consuming, and they're good for studying rare diseases, but exposure measurements are often not good. Disease status can influence how we select subjects, and when we don't know the exposure, it can be difficult to use this study design. There can be hypothesis testing with using case crossover studies. We didn't talk about this a lot in class. It's not well covered in your book. I won't spend a lot of time on it here. But what happens is cases and controls are already recruited, and there's a period of time before the person becomes a case where you can study them. This is a complicated study design. It's not one that we will use frequently, but it is an option where you look at what happened before they had the disease. One of the more common study designs that is used in epidemiology is the cohort study. Again, it's observational because nothing's being applied to anyone, but we compare individuals over time and look for whether or not they get the disease. We look at their exposures and risk factors for the disease. We look at the development of the disease or incidence, and this is one of the best observational study designs. The data can be collected going forward in time, where we recruit people and follow them over time forward, look for their exposures and look whether or not they got the disease, or we can look backward. And for workplace epidemiology or occupational epidemiology, that's a common study design. We look backwards at their records and see whether or not they were exposed. So in a cohort design, people are recruited at one point and then we follow them. We look for environmental factors if we're talking about environmental epidemiology, and we look for whether or not people get the disease or not. We don't sample this population based on disease status. Again, looking forward in time to the future, examines future events, follows conditions. In a prospective cohort study, we measure the exposure and other variables. We categorize people into exposed and non-exposed, and then we look for outcomes. If we're looking backward in time during a cohort study, we would follow events that have already occurred. So in a retrospective cohort study, we're starting at the end where we know the disease outcomes or may continue to follow them, and I'll give you one example in a minute, but we look backward at information, and this is usually through records. It could be health records, it could be records of exposure in a workplace setting. So for example, for a disease that takes a very long time to develop, we could work with employees that worked in that setting. We knew what they were being exposed to, and we follow them both forward for disease and look backwards at time at what their exposures were. The major strengths of cohort studies are that exposure status is determined before disease. So we have one of the key things that Hill suggested, which is temporality. Exposure occurred before disease. Subjects are selected before disease, and you can study several outcomes for each exposure, since you're not just classifying or selecting people based on their disease. The limitations are that these are often very expensive and take a long time. They aren't good for rare diseases or diseases that take a very long time to develop. And because you're following people for a long time, even if you're just using medical records or other records, you can lose them during the study. They can stop working at the factory, the person can stop engaging with the medical, they may move, etc. As I mentioned before, there are some studies, especially in environmental health, they're rare, where the investigator can control the exposure. This usually involves randomly assigning it to groups, and it is the best evidence for doing a test of whether or not the exposure causes the outcome. The subjects are receiving treatment, and there's a control group or a comparison group. This provides the most convincing evidence of the relationship between the exposure and the effect. However, it's very rare we can use this, especially when the exposures are harmful for ethical reasons. Here's the example. You have a study population, you apply an intervention in a control group, and then you follow this for the outcome. For the study that the students presented about the randomization of the cleaning up of vacant lots, this is exactly what they did. They recruited a city, they randomly assigned 3 arms actually, so they had 2 interventions and 1 control, and then they looked for outcomes. These are the gold standard, although we know that this can be very challenging to achieve. So we see very few of them. They're very expensive to do, and it may be unethical to employ them. So we don't do them in many situations. So I hope that this presentation has helped you understand in more detail the differences between different epidemiologic study designs that are used to understand exposures and outcomes. When you think about how we examine these, it is key to environmental health that we know what the strengths and weaknesses are of these study designs and how they work to give us evidence.